I always hate to interrupt the great collegiality that happens at the start of these meetings and get down to business things. I think one of the most fun parts is reuniting and spending time together with old friends and getting back together. So thank you for coming and fellowshipping each other tonight. As I said, my name is Jason Hoagland. I'm privileged to be the president of Ogden Surgical and serve you as this conference chairman tonight and for this week. I guess we'll have a more formal introduction tomorrow night and tomorrow during the day, but I really want to share just a few thoughts about where the catalyst for this conference came this year. Really three things. I really felt honored to be part of this august body. 72 years, the oldest conference west of Mississippi, and each of you are part of that, part of that history. And real privilege to be able to serve you tonight with that. Second is, I didn't learn it through medical school, but I learned it at Wood Badge training through the Boy Scouts about leading change. In medicine, we really don't spend a lot of time developing leadership. But at Scout Camp, I learned about directing change and felt like that this is something that's happening to us right now, that we're in the midst of change that needs to be directed. And that I wanted to be able to provide for you some look into the future about what medicine may be 10, 20 years from now, so that you won't be really acted upon with change, but will be leaders of change in all the facets that you serve in. And one last area that meant a lot to me was as I read Gladwell's book about David and Goliath. I thought about how each of you are very successful and you've worked hard, maybe pulled up by the bootstraps to get here, but will each of you be able to also to pass on to your kids the values that you have and the work ethic that you have, help them also be successful. So part of our conference will be about helping you to be able to transmit to your children, becoming successful as well, which is a concern that I have for each of us that have worked hard to get where we are. I'd like to begin tonight with some wonderful speakers. Dr. Anderson will represent Ogden Clinic. Dr. Anderson's an ENT at Ogden Clinic, who's fellowship trained in otolaryngology, allergy, and head and neck surgery. He's been an active member in the medical community and has served as president of Ogden Surgical Medical Society, president of the Utah Otolaryngology Association, and president of the medical staff at Ogden Regional Medical Center. The Utah native, Doug Anderson, enjoys trail running, traveling with his family, and cheering on the Utah Jazz. And I can vouch for that because he and I were at the Warriors game. He sat behind me, and he was very loud. And so with that, I'll introduce Doug Anderson.
Thank you, Jason. So I have the privilege of being able to thank the Ogden Clinic for sponsoring this Tuesday evening registration pre-conference meeting and social event and dinner. We are so grateful for the many sponsors that help out with this meeting. It makes it possible, but the Ogden Clinic especially has been a very strong sponsor over the years of the Ogden Surgical Medical Society. They're a strong force in this community who has been a great advocate for enhancing medical care and providing excellent and quality services. They now are expanding and serve both Weber and Davis counties with 16 locations and 20 medical specialties. They have over 800 people that work at the Ogden Clinic, and the Ogden Clinic has more than 130 practicing providers. Over the past year, the Ogden Clinic had the opportunity to partner with 4 outstanding practices which have recently joined their ranks, and they include Davis Family Physicians, Cope Family Medicine, South Ogden Center for Family Medicine, and Mountain West ENT. They are all now part of the Ogden Clinic. Our services now span from Brigham City to Bountiful, and they have a commitment to accessible and quality health care, and that's what drives patients, employees, and providers to the Ogden Clinic. At this time, we'd like to have all those who are members of the Ogden Clinic please stand so we can recognize you. If you are here and from the Ogden Clinic, if you wouldn't mind standing. Thank you very much for sponsoring our meeting tonight. Well, tonight we'd like to start off with an excellent talk on Hereditary Cancer Syndromes, Why Should I Be Testing? And our speakers will be Dr. Megan Grunander and Dr. Amber Bradshaw-Whitear. And we'd like to turn the time over to them at this point.
All right, I want to start out and test our mics. Can we be heard in the back? We okay? Thumbs up in the back, we're good? Okay, awesome. I'm not normally a quiet person anyways, but I don't know if I could reach all the way to the back without this mic. So Megan and I are really honored to be here tonight, and we want to just thank the Ogden Medical Surgical Society for having us. This is a topic that we are really passionate about, that we love. We know that's going to come across in what we have to give you today. And we hope that some of that passion will go with you into your practice and how you can change to make this a part of your practice. So we make sure we've got our slides up here. None of this is our slides. Maybe it'll come. Oh, here we go. So we've got some objectives for CME. Why should you screen? We're going to talk about that. Who to screen. What to do with positive tests. If I could give a #1 reason why people don't test, it's because they get scared of what to do with a positive. And so we will reassure you, we will walk you through all of this. Uh-oh, it's going through without me even doing anything. So Megan does not have any disclosures, and I'm a speaker for Myriad Genetics. So the first thing we're going to talk about, if it won't go past our slides, is why we personally screen. And I've actually been screening since I was a fellow in Florida. And my first patient that got me really starting to screen is not this one. I'm going to talk about her in just a second. But my patient that came in had a mom with ovarian cancer. And the first time that you diagnose somebody with a gene like BRCA, which I did with her, and you take out her ovaries and save her life because now she's not going to get ovarian cancer, that is hugely rewarding. And we'll talk about that a little bit later as well, but that's how I first got the bug to start hereditary cancer testing. This patient up here, it's not her actual picture, and I'm not going to use her actual name, but let's call her Jane. And Jane came to see me about a year after I'd come to Ogden. I was still doing annual exams at that time. She was 65 years old, comes in to see me for her annual exam, and wasn't really there for any complaints, but we started talking like I do with all my patients that come in about her cancer family history. And she had 4 family members that had ovarian cancer that had all died from this, and then 3 family members that had had breast cancer. And so I say to Jane, I said, Jane, has anybody ever talked to you about BRCA testing? This is a really strong family history. I think that we need to get you tested. And Jane says to me, I was tested 10 years ago. We were in the initial study that looked at BRCA. And I was like, well, what happened? And she said, they told me I was positive. And so I'm like, Jane, you still have your ovaries. I'm like, who's been watching this? Who's been screening you? You still have breasts? Are you doing all, breast MRIs? And she's like, no, nobody's ever actually mentioned this in the 10 years between then and now. You were the first person to ever ask me. Nobody's been screening me. Nobody's been doing anything. Nobody's even asked the question. So at that point, there was only one company that was doing BRCA testing at that time. So I called the company to get her results. They have nothing. So it must have been even the initial studies at the University of Utah that were done. So I retest Jane, and Jane is BRCA1 positive. So once I know this, I get an ultrasound, and she's got a 3-centimeter mass, and her CA125, which is the level that we look at ovarian cancer, is mildly elevated at 87. So we take Jane to the operating room with the GYN oncologist, thinking there might be a cancer there. And luckily enough, Jane has a stage 1 ovarian cancer, which we never catch it that early. Jane had her surgery, Jane had 3 rounds of chemo, and Jane's still alive today. And that's a huge thing to say for ovarian cancer. We don't get to say that very often. And Jane's alive because I asked a question. I asked a simple question. It took me minutes in the office that nobody ever had asked in 10 years of seeing primary care doctors and other OBGYNs. Nobody asked that question. If we'd waited 3 more years, Jane may not be alive today. And I feel so strongly about that we are here today to talk to you about how we can all save lives together.
I'm going to talk to you about Katie, and I see some of the GI doctors here. And
Went too far.
Oh, sorry.
Not your butt.
And you guys will all know Katie. I have her permission. This is me and Katie. She's a tech in the GI lab. She was initially at Ogden Regional. She's now at McKay. Her mom had a diagnosis of breast cancer a number of years ago, and because of a strong family history in her mom, aunts, her mother was tested and came out BRCA positive. So at the age of 24, Katie was tested, and she tested positive for BRCA. So we started screening Katie at the age of 24, screened her for about a year and a half. She had a 1-year-old at the time of her diagnosis. She subsequently went on to have another baby, and so during her 9 months of pregnancy, and then for about 9 months after her pregnancy while she was breastfeeding, we didn't do any screening. When she came back to me now at the age of 27, and this is 3 years into her BRCA diagnosis, she came back just to reestablish care. She's done breastfeeding. We get imaging. She now has a breast cancer at the age of 27, and with a 9-month-old and a 3-year-old at home. So Katie now has undergone bilateral mastectomies. She's also had a hysterectomy and bilateral salpingo-oophorectomy, and she's now cancer-free. It had not spread to her lymph nodes. She was a stage 1 cancer, but we diagnosed her at 27. She's now the youngest breast cancer patient I've diagnosed since I've been in town. And then just briefly, I'll tell you about someone today who she came to me actually, was referred from a primary care provider for gallbladder disease. She was 6 weeks postpartum, had gallbladder issues during her pregnancy. While I'm doing my history and physical on her, I took a family history, and she tells me about her mom, who died at the age of 42 of ovarian cancer, and an aunt who had breast cancer, and I'm like, well, this is suspicious. Why don't we test you for something? So she actually just followed up with me today, and now at the age of 31, we've diagnosed her with BRCA1 because she came in to have her gallbladder out. And we're now going to change the course of her life, which now won't mirror her mom's with an early cancer death in her 40s because she has a gene mutation that she doesn't know about. We're going to now, she's seen Dr. Whittier already, she's seen me, and she's now moving on with getting her prophylactic surgeries done. So this is why Amber and I are so passionate about this, because we really are making a difference in these patients' lives.
Megan gets to save lives all the time because she's a trauma surgeon. I do things that make people feel better. I pull up their vaginas when they're falling out. I take out their uteruses when they're bleeding. I make people feel better, but this is the one thing I do that saves lives. And so I feel particularly proud. She's a lifesaver all the time. So let's just talk a little bit about gene information for some people that may not be aware about it. And I don't know why this is skipping so much. Is it possible I'm hitting the wrong button? I do have baby brain, so that may be part of it. So BRCA, it's 2 genes that suppress cancer growth. Mutations or deletions can affect their suppression. So BRCA1 and 2, you can either have a mutation in it or a deletion of the whole or part of the gene that can cause these problems to happen. If you have a BRCA gene, you have a breast cancer risk that's up to 87%. It's like has a mind of its own. It's just
it really is. It's just,
sorry guys.
You're not pushing anything, it's going.
Oh my gosh. It's like on automatic somehow. I don't know if we can change that. Otherwise, I'll just keep going back. Ovarian cancer, depending on the gene, BRCA1 is a 40% ovarian cancer risk, and BRCA2 is a 20% ovarian cancer risk. The male breast cancer risk is around 2 to 7%. They also have a pancreatic cancer risk that can be up to 7%, prostate cancer of 20%, and also an increased risk of melanoma.
So I'm going to talk to you for a minute about Lynch syndrome, which may be common or familiar to some of you. So there are multiple genes that are associated with Lynch syndrome. The most common ones truly are the first 3, MLH1, MSH2, MSH6. There are a number of cancers that are associated with the Lynch mutation, that being colorectal cancers, uterine cancers, ovarian, pancreatic, gastric, renal and urothelial, and then also some melanoma as well falls into this. The colon cancer risk for these patients is up to 82%. The endometrial cancer risk is 71%, and the ovarian cancer risk is 12%.
So we're also going to talk multiple times in this presentation about other genes. So I briefly just want to comment, but we'll go on to talk more about this, that BRCA1 and 2 and the 5 genes that go along with Lynch syndrome are not the only genes out there that we know cause breast, ovarian, colon, pancreatic, all these cancers. And so we'll talk about how to test and why we test for some of these other genes. But there are multiple others in each of the cancer classifications.
And I can tell you, just looking at this screen, the patients that I'm following now that have mutations, I have a patient with MUTYH, I just did a colonoscopy on last week, CDK4, CDH1, multiple PAL-B2 patients, multiple CHEK2 patients, a BARD-D1 patient, and a RAD51C. And we actually, my RAD51C, we just diagnosed her daughter with the same mutation as well. So out of these, that's probably half of that list that I'm following patients with other genetic mutations besides BRCA and Lynch.
Yeah, I probably have more people with non-BRCA mutations. I only have a couple Lynch right now that I'm following. Most are other genes. And in 10 years from now, we're going to even know a whole lot more. So this talk may be completely different. But we'll talk about some of the screening and management of those other genes as well. So I want to talk a little bit about why everybody should be screening. And not only do we talk about it just saving lives, but it also has become standard of care across multiple specialties. ACOG, which is my governing body as a gynecologist, has come out with both practice bulletins on hereditary ovarian and breast cancer, as well as Lynch syndrome practice bulletin statements. And it says that this should be a common part of an OBGYN's practice, that we need to be screening, testing, and treating these patients because those cancers are cancers that we deal with. And so ACOG has said that. Then also the U.S. Preventative, it just has a mind of its own. U.S. Preventative Services Task Force came out and said that this is level B recommendation. And as a level B recommendation, it means that it goes under the Affordable Care Act if they meet their criteria, which they won't, they're kind of secretive. They won't really tell us what their criteria are. Then it's 100% covered under the Affordable Care Act. And so in this statement, it says as well that primary care need to also be screening, testing if they feel comfortable with it. We'll talk about referral patterns if not. But this needs to be a standard of care thing in our practice because our governing bodies have said that it is. And so medical legally, and we'll talk a little bit about that, might even be next, yeah. Medical legally, we are at risk for not testing. So this is an actual case, Down versus Trias. It was in Connecticut in 2012. And it started with a 45-year-old woman who met criteria for genetic testing. She actually had 4 family members that died from breast cancer. And we'll talk about who meets criteria, but that is an absolute 100% this meets criteria to be tested for genetics. The physician failed to recommend genetic testing, failed to discuss any link between breast and ovarian cancer and in genetically positive patients. So the patient who went to see him for an unrelated thing to her genetics, she was actually having bleeding, had a supracervical hysterectomy and her ovaries were left, which in a 45-year-old without a family history of any genetic cancers would be totally appropriate. But in this case, she should have had hereditary cancer screening. So 1 year later at 40, what was she, 45? Let me go back. Yeah, so she was 45. So 1 year later at 46, she develops ovarian cancer, very early ovarian cancer. And so she sued her physician for failure to properly treat her from a breach of standard of care. Because the failure was that he needed to recommend genetic testing with 4 family members with breast cancer that should have got BRCA tested, which she was positive, and they would have caught her ovarian cancer or prevented her ovarian cancer the year before by taking her ovaries out. So in this trial, the jury awarded her $4 million for that breach of not testing that patient. So this is a medical legal liability that we have to think about as providers. It's definitely not something that 10 years ago we were really even talking about, and now it really needs to be coming to the forefront of things that we're screening for.
So who should we screen? We're going to start by just talking about BRCA testing in patients that have a cancer diagnosis, because that is where a lot of this starts. They come to me with a new breast cancer diagnosis, or they present to Amber with an ovarian mass, and that's where a lot of this testing gets started. So any breast cancer patient that comes to me that's 45 or younger automatically gets tested. Now that has changed within the last 2 years. It used to be 50 and younger, but now the recommendation is 45 and younger. In a female that is 50 or younger with a new diagnosis of breast cancer, if she has 2 separate primary breast cancers, or if she has a relative with breast, pancreatic, or prostate cancer, and ovarian really falls in there too, but ovarian also is kind of its own variant, then that patient qualifies for testing. In a patient that's 60 or younger but has a triple negative breast cancer, meaning estrogen receptor, progesterone receptor, and HER2 new negative, they get tested.
When you're talking about cancer risk, are you talking about the absolute risk because the test is positive? Or are you talking about the relative risk because of the full risk?
So when they look at risk, it's risk by the age of 70 years old is how they've standardized that. And that's across everybody. So they'll give you a risk, like if you got positive genetics back, they'd say this is her risk by the time she's 50, and this is the risk by the time she's 70 years old, which most people will say is her lifetime risk. So that's where that risk of breast cancer of 87% comes from.
Correct.
I didn't hear.
Yeah.
Okay, sorry.
Yes.
Okay.
So then a breast cancer diagnosis at any age, if they have one relative that was premenopausal breast cancer diagnosis, 2 relatives with breast cancer at any age, 1 relative with ovarian cancer, 2 relatives with pancreatic and or prostate cancer. If they have, regardless of their age, any family member with ovarian cancer actually qualifies them for BRCA testing, or a family member with male breast cancer. Now, if you're looking to do BRCA testing in a patient who does not have a breast cancer and ovarian cancer diagnosis, they're just coming to you and you've taken their family history, now this applies to these patients. So if they have 1 relative with a breast cancer at the age of 45 or younger, they qualify. 2 relatives with breast cancer and 1 of those patients being premenopausal. 3 relatives at any age with breast, pancreatic, or prostate. A single family member with ovarian cancer or with male breast cancer, then that patient, regardless of their own cancer status, qualifies for BRCA testing. Now, Lynch is a little bit more confusing because there are 2 main criteria that we go off of. The first one that we're going to talk about is Bethesda guidelines. So this is,
sorry, I'm trying to
okay.
find if there's a better way so it won't go
You're
on.
good.
Apologize.
So this, if you have a diagnosis of a colorectal cancer at the age of 50 or younger, then we test you. Under the age of 60 with an MSI histology, and this is actually interesting. These are based on NCCN guidelines, but that was interesting to me. So I actually called our pathologist today and said, how do you guys determine who you test for MSI testing? I'll send a genetic blood panel on anyone 50 and younger with a colon cancer, but for pathology, their standard is any colon cancer 75 or younger, they send for MSI testing. And MSI is the mainstay of Lynch syndrome. It stands for microsatellite instability. The way that Lynch syndrome occurs is it's a DNA mismatch mutation. And so then it causes this microsatellite instability, which then leads to these genetic cancers. When we're talking about colon cancer, more commonly right-sided or cecal ascending colon cancers, but you can see them anywhere throughout the colon. But from a pathology standpoint, they test every colon cancer submitted to them if for the age of 75 or younger.
And that just brings up just a quick point is that you'll find that different societies have different standards for testing. I personally, and I think you do too, use NCCN, National Comprehensive Cancer Network. I don't use ACOG. That's the one time you'll find me ever deviating from ACOG practice bulletin. But they really are truly up to date on all of the information. So that's what I tend to use.
Yeah. Sorry, going back to our slide. So a colorectal cancer diagnosis with 1 relative with any Lynch syndrome related cancer at the age of 50 or younger, or a colon cancer diagnosis and then with 2 or more relatives with any Lynch-related cancer at any age. And that's the Bethesda criteria. Now, if you go to the Amsterdam criteria, there's Amsterdam 1 and Amsterdam 2, and these have changed in the last 10 years. But these are maybe ones that you're more familiar with. I know when we were in medical school and residency, if you heard about Lynch, you would remember the 3-2-1. And that's kind of what made it easy to remember. So Amsterdam 1 was 3 relatives, particularly with colon cancer, 2 successive generations, 1 affected before the age of 50. Now Amsterdam 2 criteria has changed that it's 3 relatives with any Lynch-related cancer, so urothelial, endometrial, colon, gastric, 2 successive generations, and 1 under the age of 50. Now, if you have a patient that meets any of those criteria, Bethesda, Amsterdam 1, or Amsterdam 2, or if you have a patient with an endometrial cancer under the age of 50, and truly if you have a colon cancer diagnosis at the age of 50 or under, then those patients all qualify for Lynch testing. And then there's also something called the PREM model, which is an online model that you can do, that you can have patients. There's 2 pages worth of questions. It's really easy to go through. It will go through and calculate out a risk score for you. And if that's 5% or greater, then they qualify for testing as well.
when you're talking about Lynch testing, Lynch, when you look at insurance companies paying for this, they don't like to pay for Lynch syndrome like they'll pay for BRCA. As you can see, the criteria are not quite as delineated. They like to have their own criteria. They like to use old criteria. But the PREM model is one way that I can usually always get that push through insurance. If they have a 5% or greater, now, they've kind of said that should be tested for Lynch syndrome, and I have much greater chance of getting it pushed through insurance. It takes me literally 2 seconds to get their PREM score, and I can do that any time of the day as I can hold on sending their information. I can even do it at the end of the day. It just is based on what their personal history is and what their family history is for all those Lynch cancers, and then it'll give me a score. So let's talk just briefly about panel tests. So like we talked about, single to just small level gene testing is so 2010. We don't do that testing anymore. Now we panel test because, again, unless insurance companies tell me they won't pay for it, which there are a few, I learned so much more about what their genetic risk is if I look at everything we know about right now. Now, obviously, again, 10 years from now, we're probably going to know about 20 more different genes than we don't know about now, but at least what we know about now, I can panel test for. If you look at this is a 25 panel test that I use. There's 13 genes that go along with breast cancer, not just the 2. I don't know why it's doing that, sorry. 13 genes that go along with breast cancer, not just BRCA1 and 2. And like I said, we have a lot of patients that have PALB2, CHEK2, ATM. Oh my gosh, this thing's killing me. I bet it's killing you guys too. The ovarian cancer, there's 12 different, not just BRCA1 and 2. And then the colorectal, there's 14, not just the 5 that go along with Lynch. So we're looking at whole broad panels that change what their risk is and change how we screen them. So I use, like I said, a 25 panel gene. There are different ones that come with different companies. Not all insurance companies pay for it. And in that case, then I do just get their BRCA1 and 2 because that is their highest risk of breast and ovarian, or I just get their 5 for Lynch.
But then often insurance companies will pay. If those come back negative, then you can ask them to reflex test, which they'll start there and then automatically go on to the more extensive panel test if those initial ones are negative.
Yeah, there are some that will do it that way.
And so we can often do that.
So there are 2 studies, one that was published and one that was just presented in a what am I trying to say, baby brain? In a conference. Oh. Sorry, it's a real thing. Studies show that baby brain is not a real thing, but I will tell you it is. I used to be a smart lady. I'm not so smart anymore. Okay, so each one of them showed that there was a 50% greater chance of catching a deleterious mutation, meaning a mutation that causes cancer, if we panel test. So how many people are we missing not doing it? This is the study that was published. It was JAMA Oncology. It looked at over 1,000 patients that were BRCA negative, and 40 of them were positive for other mutations, and the most common were CHEK2, ATM, and PALB2. And if you look at the genetic research, PALB2 is like the up-and-coming BRCA. They think that it's going to be the next big thing.
We'll talk, this is the significance of doing panel testing. So when I first came, I've been in practice just shy of 6 years. When I first came, PALB2 was of unknown clinical significance. About 3 years ago, they downgraded it and actually said of no clinical significance. And now in the last 18 months, it has taken a full pendulum swing, and PALB2 now falls right in under BRCA as far as recommendations for prophylactic mastectomies and consideration for risk-reducing hysterectomy and bilateral salpingo-oophorectomies. So that's why this is it's changing all the time. And that's why panel testing is so important, because a PALB2, if we had missed when we were only testing them for BRCA, now we're completely mistreating them because they need to be treated like a BRCA patient. So genetic counseling, this is initially, and about 2 years ago, when the panel test, the one that we mainly use called the MyRisk panel, which is 25 genes, when that came to be, a lot of the insurance companies were requiring that patients see a genetic counselor before they would pay for them to have their testing done. Well, this is hard because there's less than 1,000 genetic counselors in the United States. So then they came around that and said, okay, well, you can do a telephone consult with a genetic counselor, and so the insurance companies would employ a couple of genetics counselors and they would talk to these patients over the phone. In a study in the Journal of American Medicine in 2015, this showed only 30% of women were actually seeing a genetic counselor prior to getting a BRCA test result back, which means that the majority of these patients were being tested because they were either having a diagnosis of breast cancer, or they had a primary care doctor that knew about it and were testing them. It wasn't the genetic counselor that was actually testing them. And so it's just not always possible. Even here in Ogden in the last 6 years, there's been a significant, Ogden Regional and McKay both had genetic counselors. Then at one point, neither of them had them. Now McKay has another one, and Ogden Regional has one that splits her time between Salt Lake and here, but it isn't always possible. So now that has changed, and a lot of insurance companies are actually letting you go ahead and proceed with this testing without having a genetics counselor. The official position of ACOG, which is the governing body for obstetrics and gynecology, is that they do not need to see a genetics counselor if you have an appropriate family history. Same thing with the AMA and the AAFP. And many of these insurance companies we're now finding when they fight it, if they actually talk to me or to Dr. Whittier, they're letting some of the surgical specialists who deal with this on a regular basis act in the place of a genetics counselor. So we are able to get this testing pushed through and paid for.
I think maybe even let's skip this one because we only have 16 minutes left.
Okay.
This next, don't you think? Mm-hmm. That's just on what to include in counseling.
Yeah.
Okay, so one thing I just want to hit on, because if many of you hopefully start testing, which is always our goal, or you're going to have these companies come in and say, my genetics company is just the same as that genetics company. It doesn't matter. We're all the same. I just want to give you a few tools so that if you start to do this, that you have your resources to pick the lab that you want to pick. So if you look at home pregnancy tests, those things are FDA regulated, meaning if a new pregnancy test comes on the market, they have to demonstrate that they are equally as good as the other pregnancy tests. They have to have the same sensitivity and specificity, and the FDA regulates that and monitors it and wants to see the studies. Well, when it comes to genetic testing, they're not FDA regulated. They're actually under CLIA, which is the Clinical Laboratory Improvement Act. And that's a huge difference because that's not a regulatory body. They don't have to demonstrate that they're substantially equivalent to anything. All they have to say is that they act in accordance to their own lab's internal protocols and internal standards. So they don't have to say, like, I can do it just as good as them, and here's my studies to prove it. All they have to say is, my lab's good, and this is our sound standards, and that's all CLIA cares about. And that's a huge problem. I really do hope that the FDA steps in, because people are getting the wrong result, and we'll go over that in just a minute. Significant variation, and studies have proved that. So when you look at this study from Clinical Genetics, they had 2 samples from the same individual sent to 2 different labs. They looked at 32 variants identified by that lab. And by a variant, what we mean is that DNA was not 100% normal. And in our DNA, none of our DNA is 100% normal. But do we know if that abnormality is benign, pathogenic, or we don't know yet? That's the important part. So 17 of them were classified differently by these 2 different labs. That's 53%. 53% of the time, they got one answer when the other one was actually right. And that's a huge problem. Again, each lab has its own process for determining when a variant is deleterious, pathogenic, or when it is benign. And people need to be aware of this. They are not all the same. The PROMPT study looked at people that had genetic testing. They had to enroll themselves between 2014 and 2015. They looked at all labs, all of them out there, Ambry, Color, GeneDx, Invitae, Myriad, Pathway, and Quest. Patients had to upload their lab report and answer a little questionnaire. And what they found is 518 people enrolled, 603 had variants, meaning more than one person had 2 variants or even 3. 36% were variants of undetermined significance. We don't know yet what this variant means. It's an abnormality, but we don't know. 32% were pathogenic. This is a deleterious mutation that is cancer, increasing their cancer risk. And 6% were benign. But 26%, when they looked at that, were conflicting between labs, meaning of all those 518 people, many of them had the same variants. And they could see between the labs that they were not concordant. And 26% of the time in this study, 53% in the other, they were wrong. And when you looked at that, 36% of them, their medical management would have been different, meaning they got a positive result that something was cancer-causing when they were negative, which is horrific, but also equally horrific is they got a negative result when they were actually positive. And as somebody who takes on that medical legal responsibility, that's a huge problem. We need to be making sure that the positive result is a positive and a negative is a negative. So this is an actual lawsuit that happened. Because it was settled out of court, they masked all the names. So Jane Roe versus ABC Corp and XYZ Hospital, it was in I believe Cleveland, Ohio. This is a 48-year-old who had a history of a right breast cancer. At the prompting of her oncologist, she did have genetics testing at that hospital, and it was sent to the ABC Corp for interpretation, and it came back with a BRCA positive. Thinking she was BRCA positive, she did what most BRCA positive patients do and gets prophylactic surgery, mastectomy, oophorectomy. And like all BRCA patients, once you're BRCA positive, we want to know what your children are, your brothers and sisters are, and your parents are. And we start going out to test everybody else because we have more lives that we want to save. And so her parents got tested to see where the gene came from, and they were both negative. Well, that's impossible unless there was cheating, right? Like, there's no way that she can be positive and her parents can be negative. So what happened is the plaintiff had retesting done at an outside hospital, and she was actually negative. Just going back to the thing that 26 to 53% of these are wrong depending on the lab that you use. So when you hopefully start doing this, or as we've done this, we are very careful with the lab that we use, because I would be horrified to take somebody's ovaries out, especially in a young patient, when that's not really what they needed done. That's hugely detrimental to them. So this lawsuit actually, so they sued obviously for negligence, and it settled for $2 million. And it actually only settled for $2 million because they were in a small town. Had they been in a bigger town, it would have been double or triple this. So I just briefly want to talk about what lab to look for. When a lab comes in and talks to you, if you're doing this testing, you want to look at what percentage of the gene they look at. What database do they use? This is one of my biggest things. The public database is inherently flawed. It is not regulated. It is not cleaned up. The NIH just spent millions of dollars to try, and they're still not anywhere close. So what database are they getting this interpretation from, and who's regulating it? How do they classify those genes? And do they reclassify? That's a huge one to me too. I can't tell you in the last 8 years how many people I've tested that have a variant of undetermined significance. Eventually we're going to find out, is that benign or is that pathogenic, and I want to know that. Are they going to send me that information? And a lot of labs don't. We need to ask those questions. Do they have the same sensitivity, specificity, the same supporting data, and the same control measures?
Okay, so what do we do? You've identified a patient that meets criteria for gene testing. You've tested them, and they now have a positive result. So we're going to talk for a minute about BRCA and then Lynch. So here we go. You may not have breast cancer yet, but your breast may be plotting against you. And this is these BRCA patients. They come to us. By the age of 70, 87% chance of a breast cancer. And then if they do have a breast cancer, they have a significantly increased risk of a second primary or a recurrence within 5 years. So that is really how it is. So once we've identified a BRCA patient, we start with breast exams performed by a clinical provider every 6 months at the age of 25. Breast screening starts at the age of 25, and they get screened every 6 months. So insurance will pay for them to have a mammogram, but it's not very helpful under the age of 30. But they'll pay for them to have a mammogram, an ultrasound, and an MRI every year. So what we end up doing is we couple a mammogram and an ultrasound, and then 6 months later they get an MRI. And then 6 months later they get a mammogram and ultrasound, and 6 months later they get an MRI. And so every 6 months they're getting tested and imaged. It's just different modalities because that's what the insurance will pay for. We start talking about risk-reducing mastectomies once they're at an age, they're kind of past childbearing years. And some may not be, but all it takes is that first abnormal image and a biopsy to send somebody just through the roof with stress and worry. And that's usually all it takes in patients who initially don't want surgery to then transfer over. We start talking about risk-reducing hysterectomy and salpingo-oophorectomies around the age of 35 for BRCA1 and around the age of 40 for BRCA2. The NCCN does not recommend doing annual pelvic ultrasounds in CA125s, but some societies do. Maybe you want to touch base on that?
I mean, it's controversial because if there's OBGYNs here, you know that there is really, even when we know you have a gene, there is no screening for ovarian cancer. Ultrasounds in CA125s have not been shown to increase morbidity or mortality, even when I know she's got a 20 to 40% risk. So I still do them because I feel like it does help me, but I can see where NCCN is coming from, that really even when I know, I don't know. So at some point I just have to take them out. And that's a really personal decision with the patient, if they watch their mom die from ovarian cancer, what age that was. And so really it's just a conversation between me and the patient, and I do still get them, but I can see why they recommend that.
Yeah. So for a Lynch positive patient, We start colonoscopies at the age of somewhere between 20 and 25 and do this every 1 to 3 years, or 10 years sooner than the youngest patient that was diagnosed with a colon cancer. EGD and capsule studies every 3 to 5 years in conjunction with their colonoscopies. Endometrial biopsies every 1 to 2 years starting at the age of 30. NCCN says this is an option. In my training, if we had Lynch patients, our colorectal attendings were firm on this. They got endometrial biopsies. If you had a uterus, you had a biopsy.
And I do still do them as well.
Yeah.
But since I follow NCCN, I think they're awesome. I had to put that they feel like it's an option. But yes, I still do them every year.
But we weren't trained that it was optional. Birth control can be shown to reduce their risk of an ovarian cancer. Talking about risk-reducing hysterectomy and bilateral salpingo-oophorectomies once they hit the age of 40. Sending them for annual urinalysis at the age of 25 because of that risk of renal and urothelial cancers, and then annual skin checks as well. Now here, we've kind of touched base on this as we've gone through the talk, but here are some of these other genes where although their consideration for risk-reducing surgery may not be the same, their imaging criteria still mirrors that of BRCA.
So I just wanted to go over a quick case study, maybe to have a patient that you guys would typically have in your practice, looking at a 33-year-old that maybe came in for any reason, cold, flu, could be an annual exam, and you get a family history. And her great-grandmother had breast cancer at 57, and then her grandmother on mom's side had breast cancer at 48. And a maternal aunt on mom's side had colorectal at 46. So if you look just at NCCN guidelines, this meets criteria for BRCA testing. 2 family members, 1 that's premenopausal, which 49 would be. Average age of menopause is 51. Colorectal, it doesn't technically meet the Amsterdam criteria, although a lot of us in the specialty do really try to get our less than 50-year-old patients with colorectal cancer tested for Lynch syndrome, but doesn't technically meet that criteria. So she was tested under BRCA, and she actually came back with a CHEK2 positive mutation, which increases your risk of breast and colorectal cancer, and an MSH6, which is one of the Lynch syndrome cancers. So she had Lynch syndrome and CHEK2, which is kind of unlucky. I've seen one patient with BRCA and Lynch. I don't think it gets unluckier than that. But just goes to show why panel testing is important, because had we just like BRCA tested her, she would have been negative. Had she just got Lynch tested, we would have missed her CHEK2 mutation, which increases her risk of breast cancer, and she needs breast MRIs as well as mammograms every year. We would have missed that. Now again, based on family history, she probably needs that anyways. We'll talk about in a minute. But that's why panel testing is so important. So what about negative results? What do we do with a negative? I've heard some people come to me that were tested and they're like, oh, I'm negative, I don't have any risk. And that is just not true. I wish it was. It's like life, right? Nothing is perfect in life. And when you are negative for a BRCA gene or a CHEK2 gene or any other gene, unless you have a family history, meaning that your mom has BRCA and you are negative, which now puts you at a baseline risk of 12% of breast cancer, just like everybody else. But unless I know that, which doesn't happen very often, you still have a risk. You have a family history of cancer. You don't have a gene, but you still have a family. And so what we do is we manage to that familial risk. And how we do that is we get a risk assessment. And this is mostly with breast cancer. They have not learned how to do any of this with any other cancers. And we use the Tyrer-Cusack or the Gale model. And how I do it in my practice, if I'm BRCA testing someone, panel testing them for breast cancer, I automatically have them fill out a little questionnaire so that if they come back negative or if insurance company says, no, I won't pay for it, I can get their risk assessment, so now I can treat them based on what their familial risk is. If they're over 20% in this model, and it's pretty easy, you put in just a few little data points, what their family history is, how old they are, it'll give me their lifetime risk of breast cancer. And it changes as they get older and further away from their family members, it's gonna go down. So I re-risk assess people every 5 years. But if they're over 20%, whether we just got their genes back and they're negative, but they're over 20% on their risk model, they need mammograms and breast MRIs every year. And this is NCCN criteria. I have not had an insurance company fight me on this in 3 years. Because, and if they do, all I have to do is write the letter and make the phone call and they never fight me on it again, because this is standard of care now. So other negative, so cancer screening should begin 10 years before the earliest family member, and that's usually across the board no matter what cancer they have. Colon, breast, uterine, all those things we should be screening for 10 years before their earliest family member. And colon cancer screening should be done every 5 years in someone with a family history. Do you have any other things on that? Not 10 years.
And it may be more often than that, depending on whether we find polyps, what's happening during their colonoscopy, but they definitely won't get out any more than 5 years. They won't be that patient that gets to go every 10. The one thing we should add, which this is a good slide for it. So you all, I don't know if it got handed out, but this is something that we're starting to now. This isn't a slide that we made because it's something new that we're implementing with the family practice doctors at Ogden Clinic that I think is worth touching base on. So you all should have gotten a handout that Dr. Whittier has come up with that all the family practice offices in Ogden Clinic are going to try and start using. And they're going to give them to the patients that are coming in for annual exams or new patients. And then, so we're trying to take away the stress from the primary care providers, because as we've gone around and we've talked to you guys, it's a lot. You guys are already busy. You're seeing a significant amount of patients in a short amount of time. And so we're trying to make this as easy as possible for you, but you really are the gateway to all of these patients. So we have given these handouts that you give to these patients and they fill them out, and then we're training their medical assistants to just look for the red flags. And so honestly, the providers don't even ever have to look at these handouts that they're doing. They just fill them out, they hand them to their MAs. We're training the MAs that then if the patients meet certain criteria,
which is any yes on it. That's
yes
why
on
it's
it.
easy. Any yes on the form.
Yes. They send their names to our offices. We contact the patients and then have them come in and talk to them about doing genetic screening. So you all should have gotten that handout, and that may be something that you guys can start implementing in your practices. But we're trying to make this easy as we can for you so that you can help us catch these patients.
Yeah, and whatever that is to implement it in your practice, I can't tell you enough how much this changes lives. I wish I could. I wish I could bring all my patients up here that their lives have been changed. But however you want to implement that, whether it's doing a screening and sending to a specialist, sending to a genetics counselor. When we have a great genetics counselor, they are an awesome resource. My problem is they don't test all the time, even when they meet NCCN criteria. So unless the insurance company tells me I have to, I don't use them. Because then they come back and they say, oh no, it's not, that risk isn't that great. And I've had a couple of times they've come back with a BRCA gene when we finally could test them. And so whatever it is though in your practice, how to implement it, whether it's you get trained to do it, which you can. It honestly takes me minutes to do in my clinic. We are so well oiled, it'll take a little minute to get it started, but whether it's implementing it, sending it, whatever it is, please start screening, because these patients are out there, they're in your practice, and they will get cancer at some point, most likely, and then they could pass away from this. Breast cancer we catch early, ovarian cancer we do not. We're just not that good, and we shouldn't have to be. If we can catch their genetic risk early, we should be doing this. So I think that's it. Unless there's some, we have like 1 minute if we're staying on time for questions. I think. Sorry, we didn't leave more. If anybody has one. Yeah.
I have a patient with lung, breast, and ovarian cancer. I also take care of her daughter. Should they both be screened?
That's a great question. So she said the patient herself has a primary lung, a primary breast, and a primary ovarian cancer all in the same patient. Am I understanding that right? So 100%, if she is still alive, hopefully, she needs to be screened. I would screen her first because she is the person with cancer. And most likely that sounds like a BRCA.
Yeah.
I mean, not the lung, but a breast and ovarian in the same person. And then when she comes back positive, which I think she will, all her children, all her siblings, and if her parents are still alive, I would test them as well. Need to be tested. If she's negative, everybody below her is negative. And if she's the only one with cancer, she's the only one I care about. Now, let's say mom had breast and all these people had breast, then you think, could there be something else? But if the primary person with cancer has a negative result, I worry much less about the family. But let's say that mom had ovarian and all these breasts back here, and I test a patient and she's negative, then I can tell her all her children are negative, but I can't say anything about the brothers and sisters.
Right.
Mom could have still had a gene, and she got 50% lucky not to have it. So all I can say is down below.
There's
Was there
another
someone
question.
else?
Yeah, there was another question.
So with the Affordable Care Act, the pre-existing kind of was eliminated. Now we're not sure about that. these
that's an
guys that are
excellent
genetically
question.
testing?
There
what
is
are
a
we gonna
law called GINA. GINA says that you cannot be discriminated against in medical insurance with a gene. Now, you can be discriminated against with life insurance, but you can now, even with the Affordable Care Act. Medical insurance can get your family history. You have 5 family members with breast cancer. They can deny you just off that. They can hike up your rates. So they do it just based on family history, but they can do it based on a gene as well. But medical insurance can never deny you whether Obamacare goes away or not, because there is a law called GINA that protects patients. That was a great question.
A question. Could you comment again? You were saying that the screening for all cancers should be 10 years before a family member was diagnosed. Where does that guideline come from? Is that NCCN?
That's NCCN guideline.
And
So
that's
I
for
just,
any cancers, breast cancer.
well, the two that they really talk about are breast and colon,
colon.
because those are the ones that we do the most screening for. But if someone's mom had melanoma at 50, yeah, I'm going to tell them to go start getting their skin checks with their dermatologist at 40. Same if they'd had bladder cancer without smoking, I'd get them in with the urologist for family histories of that.
Yeah.
Uterine cancer, I mean, that is hereditary. And so, but mostly uterine cancer is easy because they'll bleed. And so if they're not bleeding, I can pretty much guess. So I wouldn't really necessarily screen them for that. But a lot of cancers we start 10 years early, and that is NCCN. I just saw someone who was came in to see me for an ovarian cyst. Her dad had colon cancer at 42. And she's 37, and she was told that she just starts at 50. And I'm like, that is not right. First of all, we're behind. She's getting her colonoscopy with Dr. Grunander this month.
Yeah, but it really plays into colon cancer and breast cancer because those are the two things that we have good screening tests for. We have mammograms, we have colonoscopy, so that's where those NCCN guidelines play in.
Good question.
So I have a question.
Yes.
So
We're neglecting this.
that's okay. I have patients that are personal pay, or they have these huge deductibles.
Good question.
Yeah, what do I do with how much they
That
have
is
to
a
pay
great
for the
question.
screening, and then what are they looking at for cost?
So a lot of the companies, and again, you want to use a good one. The company that I use does have a thing that they fill out if they don't make any money. They have no insurance, and so they can get that for free. They just have to fill it out, and I hand patients that form all the time to fill out that stuff online to try to get it.
Online?
If they're
It's
online, yes, it's online.
Through Myriad, right?
Yeah.
I mean,
If we're saying what company I use,
because
that-
if you're going to start trying to implement it in your practice,
they will
it's
do
Myriad.
that. Now, insured patients are a little different because then usually insured patients make more money, but you're right, they have these huge deductibles now. And so that's a little tricky. If my patient has a huge deductible, then I usually say, if your deductible, you get surgery or something, we should test you then because it is going to be $4,000 out of that deductible pocket. And so I would wait till we can do that and just base their screening off their familial risk until that time.
But what you can do for any patient, because I'm not paid by Myriad, but that's the test I know and trust the most, so we do the MyRisk test when the patients come in and want to be tested, because I don't know the ins and outs of everybody's insurance, nor will I ever. We draw the test, it's a blood test, we draw it while they're in my office, we fill out the paperwork, and we send it to Myriad. Myriad then gets all of their insurance information, they call the insurance company, they find out how much will be covered and how much is the patient's expense. They then call the patient and tell the patient before they do anything, we have your specimen, this is what your personal cost is going to be, do you want us to run the test or not? And then it's in the patient's determination to do. If the patient says, no, that's too expensive, I don't want my test to be done, they throw the sample away and there's never a penny of a cost incurred to the patient at all. So I test everybody that's willing to have the blood test, and then we let them make that determination once they know what their personal cost will be.
And do they do that for you because you're a cancer specialist?
I don't
Because
know.
for primary care, it's a 375 cutoff.
Oh.
And so, but they are implementing that with some specialists, like they will call no matter what, and I'm hoping that they do that across the board. But my patients, I can't even tell you, sometimes I test 1 a week, sometimes I test 7 a week.
Yeah.
My patients that insurance is approved pay $100 or less, and most of them now are free. So it really, I have not had a patient come back and say this is a burden to me, because they will call them if they have a huge deductible, they don't cover it, it's over $375 for me because I'm considered a primary care, then they'll get called.
Yeah.
Did that help
I tell
answer?
my patients they have nothing to lose by sending the blood test off.
I I wanted to ask about your practice of doing the Q6-month screening with the alternating mammo ultrasound and MRI. Is that research-based, that we're actually going to be catching something quicker? That just seems like an awful morbidity to put these girls and women through, to every 6 months be just losing sleep over the fact of, are they going to kill me yet?
Oh, and
it's terrible.
I just want to comment before you comment on, is that necessary? Most patients that this happens to feel empowered because they had moms and aunts that died of this that they watched. And so I do have some patients that are freaked out, but I would say 90% of my patients now are like, thank you, I feel like I'm doing something, I'm gonna catch this. I feel like I have a handle on this and we're gonna be okay. Rather than like scared and it's gonna get me.
It gives them the option of then not having to feel like they have to have surgery right away. But is it fail-proof? No. I did a BRCA patient who, she's 38, was tested because of family history. Mom had died at a young age of ovarian cancer. She's 38, so she had had breast imaging starting at like 33 and then had kind of fallen away, had definitely not been doing the Q6-month screenings, came to me and decided, okay, I'm ready to have bilateral mastectomies. So since she hadn't had any imaging, we did a mammogram and an ultrasound on her. They were both normal. When we did her mastectomy, she actually had DCIS when we got the specimen out. That was not caught on imaging that time, but would have been evident 6 months later. So that's why we do it, because when we have to catch it early because we know their risk is so high. Now it does cause a lot of stress in patients, and like I said, it usually only takes one time for the patients that don't want surgery right away to have abnormal imaging and go through that process of a biopsy. And even when that biopsy is benign, that usually pushes those patients over into having bilateral mastectomies because they can't take the stress of worrying next 6 months if something's going to be positive the next time.
But it is based on data.
It is.
They wouldn't do it without that.
Yeah, and insurance pays for all of it.
Yes. Last question. Is that okay? Well, this is last question.
Okay. My question is since there really isn't any criteria for ovarian screening, the 10-year prior for breast cancer and colon cancer, it makes sense.
That's a great question.
But what about
ovarian? You're right. Cancer? It doesn't really apply to that because there is no screening. I mean, back in the day.
But don't you think 10 years before doing a CA-125 would catch it?
No.
Why not?
And studies show that. Studies show even when I know they have a 40% risk of ovarian cancer, I don't save their life or improve their morbidity by CA-125s because it's inherently flawed. It's not a great test. A lot of people that have cancer aren't CA-125 positive. It's the best screening, but there's other things that make it positive too. Stage 4 endometriosis, fibroids, any pelvic pathology can elevate the CA-125.
So you're saying if it was false positive or false negative, you could do.
But even a negative hasn't been shown to be reassuring.
Really?
I know, I'm sorry. I don't mind if people do it. I still do it sometimes too. Okay. I mean, the best thing we can do with patients that their moms died of ovarian cancer is get them BRCA tested.
Okay, but what if the mother was negative? And I mean, we have a family right now that, the uncle has pancreatic cancer. The mother has ovarian cancer. The great aunt has ovarian cancer. The grandmother has breast cancer. And the two relatives that have been tested for gene mutation is negative. And then there's these two daughters. So how do you screen those two daughters?
There is no screening. So what I would say if they came to see me is 2 family members with ovarian cancer, you're at an 8% risk of ovarian cancer with 2 family members. If you're having other problems and and insurance will pay for a hysterectomy, we can take your ovaries out prophylactically. I have even beat insurance just by doing it off of family history. But they're really, ultrasounds and CA-125s may make us feel better, and I still get them, but studies show that there is nothing that is going to catch her cancer early.
All right, thank you.
Yeah. Thank you, guys.
Thank you.
Oh, we got it.